Start us off, can we have Dr. Beccy Cooper, please?
Thank you, Chair, and thanks so much for coming this morning. I want to dive straight in and look at commissioning and provision of sexual health services. So we've had a number of organisations submit evidence and opinions to us, and we, perhaps unsurprisingly, have heard that split commissioning isn't always giving us the best results. So, for example, the LGA have said that split commissioning between local authorities, NHS England and integrated care boards has resulted in a fragmented system, which has resulted in inconsistent access, gaps in services and poor coordination. So I wonder, perhaps, as the Chair said, we perhaps don't have all time for all four of you to speak, but I don't know who would like to go first, perhaps Rob, yourself. What aspects of this fragmentation are the biggest priorities to address, and how would you like to address them?
Yeah, I think exactly what you said, the system is fragmented, and I think one of the key areas that we need to address is understanding that we all work to a whole system approach. You know, it's very ingrained with us within local authority that we cannot do this alone, and we've heard the scenarios and examples given this morning, that there is that importance of that whole system approach. It's about using the evidence around local need and working consistently to deliver those high quality services. I think
sorry, Rob, but just trying to get to the heart of it. I mean, this is, you know, it's now commissioned across several different providers, several different organisations, as commissioners. Is that ideal, or should we think about one specific commissioner moving forward?
I think ideally there's a place for each one of those services and those organisations to deliver that. I don't think it can be done by just one organisation. I think the key area is to make sure that everybody understands their role within that system.
And so, forgive me, but the gaps that are coming about as a result of that split commissioning, is it worth those gaps to have the benefits that you're talking about?
Well, as we talked about earlier, if we had a very clear strategic strategy around sexual health, which had very clear governance, very clear outlines about whose responsibility is to do that commissioning, it would be very clear. At the moment, for example, integrated care boards are under extreme pressure. That has a knock-on effect to local authorities. Some areas have very good relationships with their local integrated care boards, the majority don't. And then therefore, if we had that clear example, back in 2014 we had the Making It Work document from Public Health England. It had the commissioning responsibilities clearly listed. But as years have gone on, we've gone from clinical commissioning groups to ICBs. ICBs are now being reconfigured. Local authorities go through restructures in various different forms. Some of these guidelines are up to interpretation, and therefore within each local area the interpretation can be different.
Yes, no, fair enough. It sounds a tumble dryer of a mess, quite frankly. So, sort of prior to the splitting up of public health coming out of NHS, etc., is there a case to say actually sexual health services should be commissioned via the NHS? There should be a national commissioning service, off it goes, rather than splintering it at a local and regional level?
One of the key areas for local authorities is that evidence-based approach. We know our local area. We know what's going on at a local level. We work across the sector. We commission drug and alcohol services, school nursing, children's services, adult care, so we understand the different complexities around that.
Absolutely, Rob, but with respect, the NHS should be doing that as well. It should be evidence-based and data-driven.
Yeah.
So, you know, so it's great that public health is doing that and local authorities, amazing, but the NHS should also be doing that at an ICB level and arguably at an NHS England level. So the sexual health service provision, should it be all in local authorities or all in NHS, or you're making a clear case for as long as there's a strategic document or clear guidance from the NHS, it can in effect be commissioned through both arms, through local authorities and the NHS?
Yeah, I think the partnership working around the medical side, the social care side, have to work closely together. Sexual health is not just a medical issue to address. As we heard earlier, there's the education side of things. There's meeting the needs of different groups. We're now seeing areas around migration, homelessness, issues around drugs and alcohol. That will not be addressed solely within the NHS. So we have to have that clear working arrangement where we bring that public health element, the issues around behaviour change, understanding local need, alongside that medical support
And again, Rob, forgive me, but integrated care boards, the idea of integrated care boards and their sort of broader partnership working is to bring that more holistic way of looking at things into the mix. So is there not a place for sort of at that regional level, we talk about devolution here, to look at something like sexual health and go, rather than have separate commissioners, we have it in one place and we bring the expertise to that one place?
I think a regional footprint does make absolute sense. And with the reconfiguration of ICBs, that may help us. That may help us across. We won't be duplicating or trying to do something at a local level. We can do it across regionally. So I fully support that. But unless the ICBs and other colleagues understand their role in that commissioning arrangement, what is their responsibility and that of the local authority, we're never going to move forward.
Okay, that's clear. Thank you so much. So, Zara, perhaps if I could move on to yourself, talking about the work that you've been involved to deliver better coordination of services, what lessons would you like to bring to the committee that we can learn from this?
Okay, so for example, a 55-year-old woman coming to my service who wants a hormonal coil fitted as part of her her HRT regime, I can't fit it for her. I can't fit it for her because I'm not paid for it. So that woman with her perimenopausal symptoms will then get bounced back to her GP. GPs are less inclined to fit older ladies. They're often more tricky fits. My service, I've got lots of coil fitting appointments. I've trained my senior nurses to fit coils. We have lots of appointments. I literally could fit that coil probably the same day or within a couple of days. But no, I can't fit it because I'm not paid to do it. So she gets bounced back to the GP. The GP then bounces her to gynae, where she will be sitting on a waiting list for 18 to 24 months, unless she can afford to go privately, waiting for that coil to be fitted. So that is the reality of the fragmented service that we have.
Thank you, Zara. That's a very clear example, I would say. I'm not sure I have anything to add to that, apart from to hold my head in my hands and go, dear God help us. Excellent. So that is a clear example of where we are absolutely failing patients, and we are not, as the previous panel said, putting the patients at the centre of our care.
We need to wrap the care around the patients. Women's health hubs are a very good example of where that's happening. So it is possible, and there's some great examples around the country. But yeah, that's
okay, and that goes back to
example.
That goes back to understanding commissioning, who's doing what, where the holistic
the money is flowing. Absolutely.
Yeah, thank you. That's very clear, and that that's not unfortunately that's not a theme that we haven't heard before. So, are there any further opportunities to better integrate sexual health care with reproductive health care? I don't know if Matt, you want to talk about this at all.
Yes, thanks very much. I mean, Zara's experience is the experience I had in clinic last week. Fragmented commissioning means you can't deal. You have the skills, the knowledge, the ability, but you can't. It's not funded, and the queues are set up wrong. It's setting the woman back to gynae. She's in that list 2 years. It's a nonsense, and it does need addressing urgently. Strategic intent may help. However, it's not that the doctors or the nurses seeing the patient don't know what to do and can't do it. It's ensuring that the commissioners ensure the money follows the needs of the patient, and the time spent in duplicating the conversations to get this most simplest thing done. The woman's being examined by me. I could do her smear, but I'm not commissioned, so she has to undergo that invasive speculum again elsewhere. I think I completely agree with Zara. We have to move commissioning in a way that maximises the benefit to the patient and reduces wastage throughout the system.
Excellent, thank you, Matt. I think we put you in charge. You and Zara are in charge. That sounds great. Okay, so Tim, if I can just move to yourself. NHS England, merging NHS England into DHSC. Do you think this provides a possible opportunity to address some of this fragmentation issue, if not all? And where do you think NHS England functions relating to sexual health should fit in the future?
Yeah, thank you. So, I mean, that merger is subject to legislation being passed, but, that is the expectation. I suppose the key bit is that things that are currently commissioned at regional level in NHS England will in future be done by ICBs. So I think, as you said, Rob, I think there is an opportunity around the new role of ICBs as strategic commissioners and their need to understand local population needs, I think, is really key. I'd also probably link this to the implementation of the 10-year health plan, if that's okay, because I think that structural change is part of a broader strategy to, which is about producing more joined up services ultimately. So I think if you think about the neighbourhood health agenda, which is part of the 10-year health plan, it's very much about having neighbourhood health plans agreed between ICBs and local authorities, so led by health and wellbeing boards. So I think there's an opportunity there for better join up at local level between ICBs and local authorities in future.
Okay, thanks, Tim. And where there's opportunity, as we know, there may also be some threats. So with this merger, with the ICB regional footprint and NHS England going into DHSC in whatever manner it ends up doing, so for sexual health services, are there any threats to this service from the ongoing organisational restructure that you would like to identify?
I think we're aware that as commissioning responsibilities move from current NHS regional teams into ICBs, there needs to be a smooth transition of those things, and I think probably the year 26-27 is when that will happen, and there needs to be really good joint working, which I am seeing in my region between sort of regional teams and ICB colleagues at the same time. I think it's an organisational change risk really that I think is being managed at present. It's not unique to sexual reproductive health services, I suppose. It's part of the wider system change. Yeah.
Thank you. Back to the chair.
Thank you very much. Over to Dr. Beccy. Round us off.
Thank you, Chair, and thanks so much for all that information. We're gonna finish with strategy. You're going to be delighted to hear. So, this may be a rhetorical question at this point, but I'm going to ask it anyway for the record. What do you think a national sexual health strategy would be valuable for future commissioning and service provision? You could just say yes or no. You don't need to go into it. So if I go down, Matt, what do you think?
Yes.
Fabulous. Zara?
Yes, definitely.
Lovely. Rob?
Absolutely.
Fabulous. Tim? Tim from the Department of Health there, Tim.
Yeah.
Go on, yes, let's hear it.
Yeah. Well, obviously government recognises the need to improve health in this area, considering what to do next. I think the focus at the moment is on delivering quite a lot of other strategy in this field. So, the 10-year health plan, we have the HIV action plan, which I think we haven't spoken about much, but I think is important because I think it has implications for wider sexual health services. So part of the HIV action plan will be about stabilising and supporting system enablers. So I think that's an important bit of strategy. We've mentioned women's strategy, men's health strategy, and also the LGBT plus health evidence review that's being done by NHS England at the moment. So there's...
Excellent, Tim. I think we've also mentioned the fragmentation of services, and perhaps the fragmentation of strategies might apply here as well. So perhaps, Tim, we'll talk about the most important strategy at the moment, which is the 10-year health plan for England. So our excellent researchers here, our fantastic clerks at Health Select Committee, have been through with a fine-tooth comb, I presume, and they tell us that there is one mention of sexual health in Fit for the Future 10-year health plan, and it is, many thanks for doing this, on page 83. And it says, a new partnership with local government. Always a joy. So, and this mentions a public health grant of almost 4 billion in local health outcomes. It's already been mentioned that this is a real terms increase. One mention, Tim, of sexual health and the 10-year health plan. What do we think about that in terms of prioritisation and how we're going forward here?
So, page 83 is the most important page of the strategy.
Absolutely. Fabulous.
Just to be clear. More seriously, the 10-year health plan was not setting out to give strategy on individual conditions or for individual population groups. It's about creating a more joined up, better health ecosystem with the right incentives in place and the right structures in place. So you could probably find something similar for a number of other really important health conditions, that they don't come through in that strategy because that's not its intention.
Excellent, thanks Tim. Matt, how reassured do you feel that the Department of Health is going to move forward with the sexual health strategy that 3/4 of this panel have asked for this morning?
I was always taught to live in hope if you die in despair.
Lovely. Excellent. So if not a sexual health strategy, and I suspect this committee will be joining 3/4 of the panel with the call for a strategy again for the third time lucky, as we've not had a new one since 2013. If not a strategy, we do, as you say, have Susan Hopkins, the excellent Susan Hopkins at the UK HSA, who has put in place an SDI prioritisation framework. How is that working? Is that sufficient? Could we move forward from there? Who would like to take that? Zara, would you like to take that?
I'm going to defer to you, Matt.
Defer to Matt.
Yeah,
Excellent, go for it.
It's definitely outfield.
It is a help, it's a framework, and certainly action plans could be a kind of other part if a strategy is not on the table. A strategy ought to be on the table, though. I called to account that it has been recommended twice before, and it is now 2025, and we posed an Mpox outbreak which was only successfully contained through the blood, sweat and tears of UK HSA, BASHH and our partners such as THT and Love Tank. And so it's time to make good on that. If we can't make good on that, an action plan and perhaps a national clinical director to prove how important this is and how necessary it is to coordinate across this fractured system, that might be a second place.
Excellent, Matt. Rob, let's hope for a national sexual health strategy, but if we go back to the 10-year strategy, which is very much focused on the left shift approach, the sort of move from treatment to prevention, and I know all four of you are going to have heard this for years and years and years and years. But sexual health services, very much, there is a very strong preventative element of that, and this morning you have talked about the local authority role, the public health role, very much in that space. So perhaps, as Tim's sitting here listening about the 10-year strategy and its non-specific approach to this left shift, do you think there are lessons that could be learned in terms of how we can put together sexual health services moving forward in that prevention space that can help the government with its left shift approach?
Yeah, I think there is. I think the integrated pathways, how when people do get on that journey, how it could be seamless if we possibly can. And I think engaging with other different organisations and services that are available. I think also that focus on equity and outcomes, not just throughput. So sometimes we lose that. We're so focused on the numbers, how many people are we testing, but actually we need to get down to the sort of that high quality role, and that sort of what can we learn from that, and how can we then maximise some really good practice that's been happening. And one of the things we do at the Commissioners Group, we do a climate check. So we send out a survey of 10, 12 questions to local commissioners to find out what's going on. The SDR prioritisation tool. Not everyone's using it. A lot of it's to do with capacity, time to go through the toolkit, but of those who've done, it's really informing planning, and I think that's a really good start. So how do we build on those real good success models? How do we learn from colleagues who are here today and then share that as part of that broader picture?
Great, thank you. I think that's really clear, Chair.
Lovely.